do nosso seminário, você pode fazer as perguntas ali pelo bate-papo e eu transmito a pergunta para a gente ter menos interferência de microfones diferentes. Tá? Então, eu transmito a pergunta para os professores. Are we all set? I think we are all set with the microphones and everything. So, yeah, 36. I think we may begin with the introduction. Is it okay for you, Eva and Dr. D'Aiuto? Yeah?
Yeah, yes, it's fine. How many are you waiting to join at this point?
Yeah, actually we had a registration only for the Gum Health Day. So it was like 85, 90 people that registered for the Gum Health Day. But our students, actually, there are some 15 to 20 students. And then other people that are here, they are just joining the Gum Health Day, but they're also interested in listening to what you have to say in the seminar.
Perfect, fantastic.
Yeah, so yeah, it's not that the 90 people are coming here because we had different activities on the agenda. So yeah, they didn't have to attend all the activities. So without further ado, I'd like to say hi to everyone and introduce myself. For those who do not know me, my name is Joao Paulo. I teach periodontics at the Federal University of Paraná in Curitiba, in Brazil. And I'm really glad that you all joined us. And I really appreciate and would like to introduce you to Dr. Eva Muñoz Aguilera. So Dr. Eva will give us a presentation on her recently published paper, a very interesting paper about hypertension and periodontitis, the relationship, and that was supervised, and the last author is Dr. Francesco D'Aiuto. Thank you very much for both of you for joining us. Actually, we are joining you because they even provided the Zoom link for us. So we are joining your meeting. And I really, really appreciate that. And I'm pretty sure that this will be a great opportunity to all my Brazilian fellows and for me to learn a lot from the references that we have, like the world's top researchers on periodontal medicine. And as I said before, Dr. D'Aiuto and your crew, your staff, your students, you guys have a lot of fans here in Brazil. So thank you very much for the opportunity to learn with you. Okay.
Thank you very much, Joao. I'm just going to say hello to everyone. And thanks for giving us a chance to change our discussion rather than being COVID every day to talk about something else on the Gums Health Day, despite, we are living a critical and unusual moments. So I think it will be an interesting discussion at the end. I remember I was in Brazil now a few years back, so I know that this topic, usually oral and systemic health, is always interesting for everybody. So I'm pretty sure Eva, who's now part of our team, strongly will address an important topic which maybe will change the way we practice in the next 5 to 10 years, because linking a very common risk factors with of cardiovascular diseases like hypertension with periodontitis, it's actually something very relevant. I'd say that in your clinics, everyone seeing patients on a regular basis will probably know that a fair amount of people that you will see, at least 20–30% of them, will mention about something in relation to hypertension. So I feel very strongly that the topic is quite relevant, especially if you like to address general topic questions with your patients. But I will shut up. I'll pass it over to Eva, and then we'll chat later. Thank you again for the invitation, Joao. Yeah, no problem.
Thank you, Professor D'Aiuto. Thank you, Joao. And thanks to the Federal University of Paraná to offering the opportunity to talk today and have a discussion with you guys. So let me just share the presentation, if I may, and we can start. Let's have a look. Can you see it? Can you all see it? Yeah. So I would like to introduce this topic that as I started to study when I was a student at UCL. It is the relationship between periodontitis and hypertension, very topical and very, very interesting topic for me, and I hope it is for all of us. So just to understand a little bit more of how we started to think about this association and what were really the background and the main areas to look for. We will go and discuss of the background and aims. We will go to look as well as the main research questions. We have a look at the main material and methods, how we construct and conducted the study, looking at the inclusion and exclusion criteria, what were our primary outcomes, how we identify the literature, the difficulties we had doing so, how we assess the quality of those studies by looking at the risk of bias. We will discuss the main results and the strengths and the limitation, as well as we will come up with some conclusions on how this can impact into practice and research. So I hope you learn about the methodology as well, and you can actually conduct some similar studies at your university. So why did we use this topic? We can see that hypertension is quite an important condition that is characterized by a chronic systemic elevated arterial blood pressure, which depending on different thresholds and different guidelines, we can have lower or higher threshold for that. It is a condition that is really prevalent in any country, really, it's worldwide quite prevalent. And it affects the kidneys, the heart, and the brain. All those vessels are affected. It is responsible for more than 45 deaths for cardiovascular disease complications. And despite having proper treatment, it remains quite poorly controlled and therefore represents a major preventable cause for cardiovascular disease complications. We can see that the etiology, the main etiology that has been discussed throughout the years is the renin-angiotensin-aldosterone system, as well as the sympathetic nervous system, which obviously regulates the salt water and the balance and the cardiovascular function. But lately, we have understood a little bit better of the etiology of these conditions, where we can see that systemic inflammation is actually gaining. I can hear a little bit of background noise at the moment. I'm sorry. Yeah, that's better, thank you. So we could see that sort of standard mechanisms have been replaced in a way, and we have more understanding of how systemic inflammation or low-grade systemic inflammation and immune mechanisms have a little bit more impact, as well as we understand this now, into the development of hypertension and its complications. Recently, we have a publication by Libby and co-workers where, as you can see, not just other infections that may be happening in the lungs, in the gut microbiota, kidneys have an impact on the vasculature, on the vessels of the cardiovascular system. Also, how periodontitis has been described as one of these indirect mechanisms by which we can have an accelerated atherogenesis and vascular dysfunction. And this is quite relevant, as we can see. So periodontitis, we know it leads to local as well as systemic inflammation. And by doing so, it can actually impact in a number of pathways that can impact as well on the development of hypertension. It has been described as a decrease in nitric oxide or an increase in oxidative stress, and that leads to endothelial dysfunction as well, atherosclerosis or arterial stiffness. All again, quite important mechanisms in the development of hypertension. But not just that, we have to see as well that these two important conditions share several risk factors, such as smoking, physical activity, age, diabetes, or obesity. So there is a relationship involved in all of that. Therefore, the aim of our systematic review was to understand and to investigate what was the relationship between these two conditions. And for that, we conducted our PICO or PECO question. in which the exposure was periodontitis and the outcome was hypertension. Several specific research questions were developed. First one, whether patients with periodontitis had higher risk of developing hypertension compared to those without the periodontitis, whether there was a linear relationship or the more complicated, the more severe the periodontitis, if there was a higher likelihood of having hypertension, whether we had a mean blood pressure higher in patients with periodontitis versus those without periodontitis, and what was the effect of periodontal treatment in mean systemic blood pressure. So we tried to do a comprehensive review looking at several parameters. In terms of our inclusion criteria, we chose some studies, a big number in terms of observational and interventional studies. We excluded case reports or animal studies or pregnancy outcomes as well. And in terms of the population, we had adults of more than 16 years old. And again, the exposure was periodontitis and the outcome hypertension. When we had a look at the different case definitions, we found a variety of them. We tried to be consistent and thorough in our plan and in our methods. Therefore, we group these studies according to the definitions of periodontitis. Those falling into the criteria of some recognized definitions that have been validated for several associations, European or American Association of Periodontology, and have been actually validated and are consistent in terms of reporting prevalence, were grouped into a confident definition. But there were also other studies that were cited in those particular manuscripts that, even if they were not as consistent, they had some sort of definition. And we could understand that, you know, the impact may be underestimated or overestimated. That's why we wanted to see if grouping those, there was a difference in terms of the results. What were our outcomes? The primary outcomes for the study design was the adjusted dose ratio for hypertension. And again, we chose some secondary outcomes, such as the prevalence of periodontitis in patients with hypertension, or the prevalence of hypertension in patients with periodontitis. What were the levels of blood pressure in periodontally healthy versus periodontally diseased patients, and whether there were any systemic markers of the disease associated with both conditions, and what were the changes of blood pressure after periodontal therapy. The search strategy, how did we identify our publications? We had a look at 5 different databases. Maybe Medline is more familiar for most of the students. You can look through PubMed, but we also look at other different ones, such as Embase, Central, Lilacs, or Web of Science. We also supplemented our search with hand screening or looking at bibliographies from other studies. We didn't have to start with any language restriction, but we will discuss why we only came up with only English at the end. And 2 authors were independently looking at screening all these publications and doing everything in duplicated. And then we obviously combined some characteristics and some descriptive results with some meta-analysis or analytical inferential statistics as well. We assessed the quality of our studies, and we did so depending on whether they were randomized controlled trials, non-randomized trials, or observational studies. Again, I believe you may be familiar with these tools, and it's quite interesting to try and use them and see the difficulties you can go through when you have a look at that. And also, we have main results here. So we can see that each database, this is the Prisma flow diagram. So on the top row, you can see how many hits, how many studies were retrieved in each different database, and then we combine them all. So as you can see, there were a huge number of publications coming through each database. Once we remove the duplicates, that number decreased, but it's still a huge amount of work to go and screen all of those to see if they were in or out. Once we combine our efforts and we went through the main text, we came up with 81 publications that were included in the systematic review. So a large one. Out of them, we had combinations of different meta-analyses 20 were included in a quantitative type of meta-analysis and 26 on the other. So if we have a look at one of the meta-analyses, that was on the cohort studies. Only 3 fulfilled the criteria to be included in this quantitative analysis. And we could see that those cohort studies that were through observational time, those participants that did not have periodontitis, did have periodontitis and throughout the time develop hypertension, those had like a likelihood of a 68% higher chance of developing hypertension. This is a combination of the first top row where we can see the green arrows. This is also the meta-analysis where we combine the cross-sectional studies, and those where we had a diagnosis of moderate and severe case definition of periodontitis altogether. So all these studies, when we combine them all, you can see that at the end, this is representing a dot for each particular study. And when you have a look at all of them, the combined or the weighted difference, mean difference, it was 1.22, which it may represent 20% increased chance for those participants with periodontitis, increased chance of developing hypertension. When we had a look at only those studies that included severe case definition, meaning the higher the definition or the higher the periodontitis, what is the likelihood in that particular case? We could see that that level increased to 67%. But also remember that we said that we had case definitions. Those studies that were looking at a particular case definition that was a confident case definition, again, we had a 53% chance for patients with periodontitis versus those without periodontitis. And that was decreased, but also was still a 33% chance when we had a look at the studies that were not reporting periodontitis in a confident way. Also, we conducted another meta-analysis that was the first one that has been conducted looking at the mean level of blood pressure. And we can see that for those participants, again, with periodontitis, the mean systolic blood pressure was at the end 4.49 millimeters of mercury. And you may think, is that important? Why 4 millimeters of mercury is quite important? Well, we know based on different studies that every increase in millimeter in blood pressure is associated with actually a higher increase of cardiovascular disease complications. When we look at the diastolic blood pressure, this has been reported in the literature to be less linked to an association with hypertension. It's sort of less sensitive to detect an association. And despite that, it was 2 millimeters of mercury, which may not be very meaningful. What was the differences when we look at the results of those studies that were providing periodontal treatment? For those studies, we had a total of 12 interventional studies. However, all of those, only one of them was actually reporting the changes in blood pressure as the primary outcome of the study, meaning that the study was designed to test whether there was a change in blood pressure after providing periodontal treatment. All of the other studies were compiled as show some information regarding those studies that were actually reporting blood pressure changes before and after periodontal treatment. But those studies were not designed to test that one. And out of those, we could see that the changes in blood pressure was for systolic between 3 to 12.5, and diastolic was actually from no changes whatsoever to 10 millimeters of mercury. And some changes were confirmed only in 5 of the studies. And when we look at the quality of the studies, we had a variety. So we have from low to high risk of bias for all those studies. And mostly the randomized control trials had a low risk of bias, but the observational had some concerns. So we know that treating periodontitis can cause actually increase in oral health, but will it make a change in the blood pressure? Well, we still don't know at this point. So what were our limitations? So we could find, as we described already, multiple case definitions for periodontitis. We had more homogeneity for hypertension though. But also there was heterogeneity among the included publications. We know that observational studies have limitations to come up with causality associations. And only English language publications were finally included. So that also is reported in the literature with some limitations. What were the strengths? So in order to try to compensate for the limitations, we tried to conduct a very broad and inclusive search that could retrieve not only observational, but also interventional study, looking at different outcomes, different primary and secondary outcomes to look at all the possible corners of this association. We conduct a very thorough methodology, duplicating and screening, data extraction, and assessing risk of bias. Also, we included relevant data, not only from those publications reporting on hypertension, but also we look at cardiovascular disease or metabolic syndrome just to extract any data that was relevant to our study. We did several sensitive meta-analyses, as we demonstrated before, just to see if all these outcomes were looking at the same direction or if there were some disparities. And in fact, all of them were reporting the same, although at different magnitude. So what are the conclusions of the studies? We can see that periodontitis is associated with an increased odds for hypertension, higher systolic and diastolic blood pressure. The more severe periodontitis is, the higher is the risk of hypertension. And a trend in reduction of arterial blood pressure is found after periodontal therapy. But again, we need more prospective or interventional studies to ascertain really the nature of that association and whether that relates to our findings. We can have a look at the implications of that, or we can discuss that in a minute once we come open to the discussion. But before finishing, I would really like to thank the opportunity given to us by this university. My big thank you is to Professor D'Aiuto, who has been my mentor since I started being a student. Always many hours of dedication, encouragement and support in any project that I embarked, so I will be forever grateful. Thank you so much. Happy to answer any questions.
Okay, thank you very much, Dr. Muñoz Aguilera. Eva, thank you very much for your presentation. I think it was very clear, although of course we have some questions related to the methodology, but I'm pretty sure that everyone appreciated, and it's so nice to see the appreciation that you have for Dr. D'Aiuto. Our mentor is always someone that we like, yeah, we take for life. I just mentioned something in Portuguese, so for them, okay? So
sure.
Just 1 minute. Pessoal, se alguém tiver qualquer questão e não tiver segurança de escrever em inglês, pode escrever no bate-papo em português que eu traduzo para eles também, tá bom? Vou ficar de olho nas discussões ali. So just let me ask you something before going to the questions of the public. So I really liked that you published this paper in a high impact factor, but in a cardiology paper, cardiology journal, right?
Mm-hmm.
So I think this is very interesting for us, for periodontists, to show, and you had to like be careful with our writing, because we are showing actually physicians how important periodontology is for systemic health and understanding it as a systemic disease as well. So I really like the choice of the journal. I have like 2 questions. Actually, the first one is, why 16 years old? Is that because the hypertension was reported in 16 years old people? Aren't they too young to have periodontitis or even hypertension? And the other question would be, you guys talked about, you chose the dependent variable to be hypertension and the independent one to be periodontitis. So you're actually showing the interference or how periodontitis affects the heart, the hypertension. And is it possible that we have another way around, or even if we just have an association but related to some other causality, since this kind of observational study is not related to causative effect? So those would be my first questions, just to open up the discussion.
Yeah. Thank you, Joao. Yes, in terms of the first question, why did we choose that threshold? That's a very good question. So initially we had, obviously, when we started to design the study, we had a look at the different publications that were on this topic. And some of them were actually looking at databases that are large databases published in, the Enhance or the Korean database. And some of them start to measure periodontitis in 17, 16, 17, like in adulthood. In different countries, that is a different threshold. So we didn't want to exclude publications based on that. So that was really the decision. It was just mainly because of some of those publications starting to measure periodontitis from 16, 17, 18 years old. That doesn't mean that these studies were done in 16 years old, but in adults. So it was just to avoid excluding relevant literature. That was the rationale for that.
Okay, perfect. And the second one was like the plausibility, and if it could be the other way around, or even like no causative effect, just an association, because they are two very prevalent diseases, actually, kind of 50% of the population, and related to aging, related to chronic inflammation.
Sure.
And could it be just?
That is really important as well. So obviously there is the plausibility, which is the biological rationale for conducting this study was based on what we have seen for the systemic conditions. So when we can see that periodontitis can cause systemic inflammation, and not just periodontitis, but there are other sources, as you have very well pointed out. So it's our sort of hypothesis was coming from that, and we wanted to look at that end of the association based on how periodontitis as a chronic systemic inflammation can contribute towards hypertension. So that was the original hypothesis. Could it be the other way around? Of course, it could be the other way around. In fact, there are some studies published that I had to sort of put aside, and I had a big bank of those studies that were looking at the other way of the association. To me, biologically, it makes sense, but it was a bit more sensible in the other way around. And how we could just rule out that it was not a spurious association, because as you said, we have many common risk factors. We tried to do, as I presented, many different meta-analyses, and they were all adjusted for all these confounders. So we only presented adjusted meta-analysis. We didn't present the crude methods. We only presented the super adjusted based on smoking, based on all the possible risk factors. So even adjusting for all of that, we had a higher positive association. The strength of the systematic review was based as well on the number of studies looking at this outcome. And as I said, it was not only looking at an odds ratio, but we also look at systemic biomarkers, treatment, mean blood pressure, and all the results are showing the same direction of the association, again, with different magnitude. But I think perhaps Professor D'Aiuto has also his opinion. We've always been debating, is it first periodontitis and then hypertension? Is it the other way around? You know, which one was first? And I think it's a very interesting debate, in fact, yeah.
Yeah, I think that that's the best question Joao could have asked. It's true in this case we have, obviously this is an appraisal of papers that have been published on the topic. So obviously it depends on what each individual researcher did in their study, whether they chose periodontitis as an exposure or as an outcome. And you can identify mechanisms in favor of both directions. So in the systematic reviews, obviously we have shown in the past that periodontitis has an effect on endothelial function. So we know for sure that it's not particularly difficult to make the case that if periodontitis causes some endothelial dysfunction, which means that the inner part of the blood vessel is affected wherever in the body, then that might be a risk for developing hypertension. However, the opposite is true even more, because it is highly possible that people who are prone to develop hypertension and The risk factors for hypertension are some similar, some sort of specific, mostly diet related or connected to other organs functions. They could impact on the gingival tissue, and some of the markers we know for periodontal inflammations, say bleeding, that we also use, might be only a consequence of the systemic condition rather than the disease. Or, as Joao suggested, these are both markers of an unmeasured factor. So they are both connected to maybe a susceptibility of an individual. And no matter what you look at, whether it is periodontitis first, hypertension after, or hypertension first and periodontitis after, you know that they will be linked because eventually that individual will have them both in their lifetime anyway. So whether it's a susceptibility, a genetic susceptibility, whether it is their environment they live in, the changes of the genetic status, like epigenetic changes because of the environment they live, then it's not really a great sort of discovery if this was the real reason. I think it's even more complicated but interesting for hypertension, the fact that as you walk into a dental office, you probably know your blood pressure will go up anyway. So that is not something you don't underestimate. So it's important to know that in all these studies, we have that as a factor we have not measured. So it's important to know that blood pressure is affected by what we call the white coat syndrome. So you go into the dental office and you get stuff. But at the same time, and there are some studies that have shown that measuring blood pressure with different methods, so using the continuous blood pressure monitoring, the association persists. Maybe it's less strong, but it's still present as an association. So the relevance here is because it's so prevalent. So as you correctly said, I think in some cases might be even more prevalent than diabetes in the general population, because we know how important it is as a risk factor for cardiovascular diseases, and we know how the thresholds for blood pressure are changing over time. As the population ages and becomes sort of way more, and they got other risk factors, then we're seeing that the thresholds of blood pressure that are relevant for your health are going down. So that would be even more relevant to show how an oral condition like periodontitis, but a poor oral health status, could impact on general blood pressure measures. So it's quite an intriguing hypothesis. We are far from seeing a very strong, let's say, overall case in public health, but you might recall we published another interesting manuscript with a group in the UK from the University of Glasgow, showing from a large epidemiological study in the UK, which is called the Biobank, using a specific methodology called Mendelian randomization, how if you take into account the genetic similarities between periodontitis and hypertension, you can find from that very large data sets, that's almost 500,000 people, that individuals who have periodontitis will develop hypertension independently from their susceptibility risk. And this is one of the strongest observational analysis you can run nowadays to test causality, even before running an intervention trial. So if you look at those genes that are associated with hypertension, and you look at those genes or those that we believe are relevant to periodontitis, we find out that in individuals, they are definitely linked together, or meaning that if you find patients who've got hypertensions, the majority of them will have the same genes in developing periodontitis and vice versa. And you know that the association between the two conditions is probably not confounded by all the common risk factors, whether it is smoking or socioeconomic factors or anything else, or even diet. Oh, sorry, it was a long answer, but it's okay.
No, it's perfect. Yeah, I really like the way both answers.
and I can see that there are some questions that are coming up. There was one that I was reading myself, and
yeah, please go ahead. Yeah.
Show how relevant hypertension is in Brazil, where you have 25% of the population affected by hypertension. And so what would be the role of a dentist or health professionals? Forget it. I mean, it's not just a dentist, a hygienist or a healthcare professional. How relevant would be their role for discussing this association? I think it'll be very, very important, because it opens up a door which I always think many of our colleagues close, which is, how do you manage risk factors in a patient in a dental practice? And these are general health risk factors. They are not just, you know, plaque and how often you brush your teeth, or whether you got sugar intake because of decay. So it would, whether or not the implications is that treating periodontitis will lower blood pressure, there is no doubt that if you address with your patients all the risk factors causing hypertension, ultimately the patients will be better off. Yeah? They will be better off both for whole health and general health, because you inform them of the potential risks hypertension has, or raised blood pressure has, for their general health. It is one of the strongest predictor of important risk factor, cardiovascular risk over time, whether it is heart attacks or it is stroke, etc. So it's definitely an important role to highlight it. The question is, how many of you will measure it, and whether the measuring you make is only connected with the stress of the patient seeing you, rather than being a true assessment. That is absolutely true, but I'm guessing that in our practices, we don't see patients once. We see them more often. We see them on a regular basis. So in response to that questions on what role you could have, is if it was at all a factor to take into consideration, then we would find out that measuring it at different time points, so measuring overall blood pressure, it would definitely give us an idea whether a patient is truly hypertensive, or is it just the stress of seeing us mentioning, you know, an extraction or having to do painful dental experience or procedures.
Mm-hmm. Perfect. Yeah, that was Alessandra's questions, right? I think, Alessandra, if you still have some doubt, please just let us know. And then Eduardo just asked, what do you think about the new classification? Because you had, we have many definitions, and these definitions may impact, of course, they may impact the outcomes, because you have definitions related to maybe a localized periodontitis, and another that is 2 teeth at least. And then you have other definitions that include generalized periodontitis, at least 30%. Also, you have definitions of 4 millimeters of attachment loss up to 6 millimeters of attachment loss. And these are only the credited that you called, right? The credited definitions. And you also have the non-credit definitions. So what do you think about the new classification? What do you think? And I can give my opinion later as well. The new classification is going to make it easier for us to have a definition for this kind of study. What do you think about it?
You want me to start first, Eva?
Yeah, why not? I've talked too much already.
I think I had a seminar earlier on with my students, and we were actually debating this topic, because they asked me this question in a different way and say, you know, this new classification, do you think is really better than the previous one? And is it a definition or a classification that helps us on a regular basis? So is it just one-off? Now, to try and answer the question that Eduardo had, it's definitely a better definitions in terms of case than the previous one, because for the first time, the new classification has not just a binary yes or no disease, but it has a variety of measure which we can agree or not agree of extent and severity. Yeah, so the grading and the staging somehow should give us an idea whether it's a localized disease, there is a lot of history of disease. However, what's lacking in relation to general and systemic health is a measure that we know represent the best measure for systemic exposure. it's true, we have the stable or unstable status, for instance, which takes into account pockets that we believe are inflamed or not. But we still don't know exactly what it is, the minimum amount of oral inflammation or local periodontal problem that are relevant for each individual. So it's not really easy to say that this new classification can help us. If everybody starts to use it from now on, in every study that they make, in about 5 years' time, 10 years' time, obviously looking back, at least we will not have the issue we've had in these systematic reviews or in any systematic reviews that everybody uses their own classification. And everybody is using a different one, and therefore it's very difficult to compare apple with pears. So you don't know whether one was a very severe form of disease, one was a very localized. The moment we will have a same classification everywhere, the better it is. However, I just said this about half an hour ago. Do you know that this classification method is a classification used for another very common, unfortunately, sadly common disease, which is cancer? So do you believe that cancer and periodontitis have things in common? In the way we would manage and stage it? So that I think is where it falls apart a little bit, because although it's a better way of classifying the disease, unfortunately this staging and grading comes from assessing a disease that has a fairly different onset, progression, and management. So for systemic diseases, if we go into the systemic disease discussion, it's definitely better and consistent, but it's not going to do more than that in epidemiological studies, because ultimately we have not enough evidence to say that a stage 4 versus a stage 1 or stage 2 or a stage 1 or 2 unstable or stable, etc., means anything different for the systemic environment. Yeah, so we don't know yet, because there is not enough time for people to use the classification. If we look back, I think it's now what, 25 to 30 different case definitions. So each one of them complicates life. So I think it is better for the future that we at least stick with one with all the negatives, and then we will find out in 10 years' time whether it was worthwhile or not.
Eva, would you like to add something to that?
Yeah, I think it's, also the new classification includes some specifications for epidemiological studies. That compares similar to the previous one, Eke and co-workers in 2012, or the later update in 2015. And that, again, based on epidemiological studies, it intends to reflect what is it in the population. We would like to be so thorough and do perfectly our staging, our grading, but also we have to acknowledge the complications that brings about into research and epidemiological studies. There is a matter of time, cost, resources. So when they have compared with full mouth recordings versus partial mouth recordings, there are also very interesting papers, Trang 2013, that they compare really what is the impact of that. And in fact, they are quite a good reflection of what happens if you were in fact doing full mouth recording. They are faulty, of course they are, but at least you have a compromise that is fairly approximate to what you may have. The problem is, as Professor D'Aiuto said, when I encountered 18 definitions, what do we do about it? So the way we came up with a solution was to group them and then try to see if our analysis made a difference. And in fact, it did. The stronger the definition was, the higher was the association. And that, in a way, made us be a bit more, not certain, because again, we have the limitations we have, but well, this is looking into the right direction, or the hypothesis is more fulfilled in that sense.
Yeah, perfect. I think the answers, they add up, both of them. And I would also like to mention that the definition that they use in the criteria in the new classification is for clinical use, right? So there is an appendix to Dr. Tonetti's paper that says that it is still debatable, the definition that should be used for epidemiologic purposes. So yeah, because attachment loss as low as 1 millimeter, like would that be an implication for the systemic local relationship, for example? So what is the limit that we have? And also we have the questions like, is this periodontitis for everyone? Or is this periodontitis because of the way I am probing my patient and everything? So I still think that we have to come up with ideas to, for epidemiologic purposes, as was the case here.
Yeah.
Like to say for sure what is a periodontitis case, right?
Yeah.
Yeah.
I think that it's a very difficult question to answer right now, because we don't really know what are the variables we normally take on a regular basis as clinical variables to represent a window for a host response. So which definitely attachment loss is a measure of historical bone and soft tissue loss, which means that we don't know whether that happened 10 years before, is happening right now, and therefore it's a difficult measure to use as activity of disease. So it's clinically important to define, but from an epidemiological point of view, when you look at systemic factors, it might be quite irrelevant. In fact, we always use other measures. We use a variety of other measures, like the number of pockets greater than X or Y, the bleeding, the pockets with or without bleeding, etc. Now, these are all subjective, though. You can use the surface area calculation, the PISA score or PISA score, etc. What we are lacking is an objective measure that you can say this is truly representing the local burden. Yeah? Bacteria might be one, but an alternative way objectively to do it. So I don't think there is now a perfect case definition. I'm happy to answer the question that was raised. Use the last one at least to make the correct definition, which you know. Before you get to grade and staging, you need to have at least 2 sites with attachment loss in the 2 interproximal areas. Yeah. That's the minimum case definitions. But if we had an objective measure of gingival inflammation, yeah, which was done not by sticking something under the gum, but it was an effective way of calculating it, then that would be probably a better measure of defining the level of disease that you have and that you need to have a systemic impact, let's say.
Mm-hmm. Just let me ask you another question that I'm not going to forgive myself if I don't, because I saw that you write that in the paper, but I didn't see like the forest plot. I didn't go to the appendix, so I just checked on the paper itself. You have results for periodontal therapy in the paper about hypertension, right? Are they presented separately, or you group them all?
We didn't do a meta-analysis on that, and the explanation was because of what I said before. So out of all the studies, including interventional data, only one had primary outcome, blood pressure. So it didn't make sense to combine non-randomized controlled trials with, let's say, 12 patients follow-up study with a randomized controlled trial, because those were secondary outcomes measured that were reporting in each particular paper. As you know, let's say you design your study, you want to measure blood pressure, but you also want to measure a biomarker that changes, let's say white blood cells or CRP. But in fact, your sample size calculation and your primary outcome has been designed to test the main one. And you may report other outcomes in your paper. So based on that, we decided that it wasn't making any sense to combine data when we had not strong evidence as to do so. So what we did was reported in evidence tables what each particular study was doing, what was their methodology, what was the number of participants, what was the primary outcome and their conclusions. And the reason for that was that we didn't want to come up with any wrong message that was not going to be meaningful.
Perfect, yeah. And another thing that caught my eye was that you used the inclusion criteria, both the definitions, I think it was for 140 and 90 for systolic and diastolic, if I'm not mistaken, or patients using medication. So what would be the effect of controlled hypertension versus uncontrolled hypertension in your results? Do you have any idea about this?
So that is as well a very interesting question. The rationale for deciding that definition is because it has been reported in the guidelines, the European and the American. So in order to assess whether you have a patient with hypertension, you either have to measure it without, you know, having an impact on the medication. Let's say a newly diagnosed patient with hypertension, you just will be measuring their blood pressure in a way thoroughly in several visits, whatever is the threshold to diagnose that case. Or the other one would be those taking medication. So some of the studies that have been reporting large databases, the Korean, the American, the German populations, in order to assess whether your population has hypertension, you need to have that threshold so you can involve everybody, those that have been measuring and those that are already taking the medication. In this particular study, we did not do a sensitive analysis for those particular taking hypertension. We have done it in other publications that are working on, but not in this particular one, no.
Okay, perfect, thank you. Dr. D'Aiuto, would you like to?
I think the medication is very important. I think I saw a question that was asked by one of your students saying it's twofold. So one is, Joao correctly is asking, so you can analyze hypertension and the association with periodontitis in someone who's already taking medication, which means that blood pressure will be lower because they're taking whatever drug. And you instead, what about studying it in those that are not taking it, etc. So there is a difference. So if you're testing a new study, clearly you want to study both situations where, if you can, find those that are already very well controlled and see whether there is an impact on their general status or vascular status, even though they take their medications, or those that, despite their medications, they cannot lower down their blood pressure, and therefore periodontitis might be relevant for them. But some of these medications have gingival consequences. So the most commonly used medications, the calcium channel blocker, have an effect on gingival hyperplasia. And there are some others connected with that. It's not just the calcium channel blockers, the ACE inhibitors. Now they've become very important recently for the COVID-19. But the ACE inhibitors have also important effect on inflammation and the immune response. We have tons of other medications that patients with hypertension usually take. So how could you separate it? How could you make sure that the association is independent from the fact that they're taking the medications? Well, it's impossible to separate them because it's very difficult that you will have people without taking them if they've been diagnosed with hypertension. So you can study it in long-term studies, so in cohort studies where you can see the evolution of hypertension in people. And if you have good periodontal measurements, you can test the association with or without. If you're doing a case control study nowadays, it'll be very difficult to take patients that have diagnosed hypertension, but they're not taking medications. But if you can exclude those that have an obvious effect on gingival conditions, that you can exclude the calcium channel blocker or maybe the ACE inhibitors and all the other cardiovascular drugs. But ultimately, you can only study at the clinical level. I don't think you can separate what it is inflammation due to the at presentation. Yeah, we're not talking after treatment. When they come for your diagnosis, if they're on amlodipine, for instance, or an equivalent, nifedipine, and they've got massive gingival swelling, but they've also got deep pockets and poor oral hygiene, you don't know which is which. So at the moment, you can only go by a rule of checking what makes the best effect. So you can see the effect of your treatment by improving oral hygiene and see how much of that inflammation goes away and swelling. And then if that is still persistent, then you know that the remaining gingival swelling might be connected with the medications. In some patients, the appearance of the tissue is quite obvious, so you can immediately identify an hyperplasia, which is very difficult to find in inflammatory conditions, which, you know, has a very distinctive image or clinical image. And you know, therefore, that those patients in the long run might benefit from switching their medications anyway. So that's your responsibility, I think, to inform the patient and their medical doctors that switching their blood pressure medications would probably be a better choice for them. But we don't have a local test to say, look, this local problem is because of the medications I'm taking or because of the bacteria before, and the medication are just changing it more and everything else.
Yeah, and I guess moving forward as well, if we have to design studies that kind of sort of differentiate between the impact of the amlodipine, maybe we need to come up with obviously other measurements, have a look as well at the bone loss the patient has, not only at the gingival enlargement, maybe more definitions or you know, separate those groups and then test in those with that specific medication versus the other ones with the regular medication versus the other ones that don't have that medication. So there might be ways of separating that, but at the moment, you know, it's obviously a possible confounder that we have into account as well when we reported our outcomes.
Mm-hmm. Perfect. Yeah. So I think we have time, because I'm sorry, guys, but I know you keep asking questions here, but I had agreed that we are going to go up to 1 hour. And I know people get excited because we are really learning a lot. And I'm sure I'm talking for all my colleagues here from Brazil. And maybe we have time for one last question, or I can leave it to your like final words. So you can answer. The first thing is it a fact that hypertension might lead to periodontitis? Not only based on this systematic review, but based on, like Dr. D'Aiuto answered before. So how are we in terms of biologic plausibility for this relationship of periodontitis and hypertension? I think you answered most of it, only if you have any other comments to add. And the other last question, now it's the last one, would be Mendelian randomization suggested this causal association. In this case, what's your opinion regarding to future directions in the field? So this comes well with the final words that you could say, like future directions and the state of the art, just for us to end this webinar.
Absolutely. I mean, I'll just make it brief, Eva, then you make your own final statement. I think the evidence coming from the Mendelian randomization analysis is quite interesting, and in that same paper, I urge you to maybe go and read it. There is also a pilot intervention trials treating patients with uncontrolled hypertension where periodontal treatment reduces blood pressure after 2 months. So the field will dramatically change the moment we're able to perform a large intervention trial, probably multi-center and international wise or multiple groups. It start to measure it correctly and not just with an office measure, but with proper assessment, and demonstrate that at each level of blood pressure, you might have a benefit by reducing the amount of oral inflammation. Ultimately, though, I can look at it from the other side. Even if that was the case, I think in any dental office, these risk factors should be addressed anyway. Should always be a discussion you have with your patients to inform them that managing blood pressure, no matter who's causing it, is an important long-term outcome, important measure. Because by reducing blood pressure and being sure what your blood pressure is, it's almost like glucose for people with diabetes. But blood pressure for everybody will determine whether you're going to have a number of complications in your life. So an additional person that tells you this probably will improve the chances of that patient to change their direction. Whether it's a dentist, a pharmacist, a general doctor, a nurse, doesn't really matter. The message remains the same.
Okay, thank you. Eva?
Yeah, I would like to add that don't underestimate, as Professor D'Aiuto said before, that we are healthcare professionals, and don't feel afraid of discuss some matters with your patients, whether it's obesity, whether it's hypertension, whether it is sedentarism. You know, you have the opportunity to bring about those conversations and highlight that they can do better for their general health. So by stating there is an association between periodontitis and several systemic conditions, we are just not trying to make a case. We are just trying to say that obviously there is better for our patients to give that health advice overall. There's nothing wrong to say, have you looked at your blood pressure? You have really, really bad gums. Have you looked at your diabetes status? You know, you have any other health conditions that may be wrong? Have you seen your GP recently? What is your diet? You know, that may reflect on you know, some good at the end of the day. So I think that is an important message we can tell to our patients, really.
Perfect. So I really enjoyed this afternoon today. I think we couldn't celebrate Gum Health Day with more like talking about science and learning a lot from you. It was the best for us. So I really like to thank you, Eva, Francesco. It was wonderful. I really appreciate, and I know that people are talking here in the chat and also sending me messages, because everyone is saying, I love the presentation. Thank you very much for sharing. So thank you very much. Please stay safe. And I hope we can count on you on further next seminars as well.
Absolutely. Thank you so much. Thank you. You all stay safe. Yeah. Thanks very much, Joao, for suggesting it. Yeah.
Yeah. Thank you for the invite. Pleasure.
Okay. My pleasure. So
all the
bye,
best.
everyone.
Bye-bye, everybody.
Bye, everyone. Thank you for being with us. Bye-bye.
Bye-bye.